Thank you, Mr. Chairman, for that introduction. It's quite an honor to be here, and I would like to thank the program committee for the privilege of the floor and for our moderators for moderating this session. It's a real honor to be here. I don't often get to speak to an allied health crowd, but I work very closely with allied health professionals. I have 2 nurses and 3 PAs who work with our group, and we wouldn't be able to do these things without them. And so it's quite a pleasure to be able to speak to you. Now, I've been asked to talk about postoperative complications and their management in HPB surgery, and that's a very broad topic. We could talk for hours about the different complications. As you know, HPB surgery and pancreatic surgery in particular is associated with a significant amount of complications. And instead of giving a general talk, I wanted to give a talk today where I actually focused on some aspects where I really think allied health professionals can help us and make a difference in the management of these complications. So I'm going to focus on pancreatic duodenectomy, or the Whipple operation, that has an associated morbidity rate of approximately 50%. And this is well known, and even in high-volume centers, this is the baseline rate of complications. I'm going to outline some of the most common complications, and these are the ones that are often talked about. But what I would like to focus on are 2 high-impact complications. These are called delayed bleeds and chyle leaks. And the reason I want to focus on these is because the mortality associated with these 2 complications is very high, yet if we intervene and do the proper management, we can prevent fatalities. And so I think it's an important topic. Now, the pancreatic duodenectomy, or the Whipple operation, was not first done, but really first described by Alan Oldfather Whipple, who was at NYU in New York. He published his results in 1925 in the Annals of Surgery, and in that publication, the mortality rate, this is back in the 1920s, was 25%. Now, the interesting thing is, up until the 1970s, the mortality rate was still about 25%, so not much change between the 1920s and the 1970s. These are data from our institution at Johns Hopkins, where my mentor, John Cameron, began tackling the complications and the mortality of the Whipple operation. And over the next several decades, the mortality reduced from approximately 30% to about 1%. It now stands at approximately 2% because we're doing more and more aggressive operations, but a very acceptable and reduced risk of mortality. That said, the morbidity rate is not much lower. It still ranges between 40 and 50%. And what are the most common complications? And this is consistent in any high-volume institution. Those are delayed gastric emptying, wound infection, pancreatic fistula, and this is a relatively low rate that you'll see here, but these are in patients with pancreatic adenocarcinoma, so this ranges from 5 to 20%. Now, these are the common complications. I would like to talk about 2 uncommon but high-impact complications associated with a high mortality. These are delayed hemorrhage and a chyle leak. So let's talk about delayed hemorrhage first. The definition of delayed hemorrhage is variable. We define it, and most will define it, as a hemorrhage or a bleed on or after postoperative day 5. There's an international study group on this, and they describe a delayed bleed as after 24 hours. So there is some variability, but essentially we're talking about the same thing. This is distinct from an immediate post-op bleed, which is usually surgically related, which typically the management is different, as you'll see. Now, it's uncommon, but it's associated with a high mortality, anywhere from 15 to 30%, and it can be sudden in onset and often difficult to determine the etiology. We classify these bleeds as severe or significant if there's a hemoglobin drop greater than 3 grams per deciliter, if they're associated with tachycardia or hypotension, if there's a need for transfusion, or a need for intervention, such as an operation or interventional procedure. Now, they can present in 2 ways, and they're still essentially the same etiology, but they can present as intraluminal bleeding, so GI bleeding, which is manifested as hematemesis, bloody NG tube output, melena or hematochezia, or they can present as extraluminal bleeding, which includes blood in the drain, abdominal distension with hypotension, or a drop in hemoglobin, and bleeding from the surgical wound, or both. Now the question is, what is the best management of a delayed bleed? Because we know the mortality is high. Is it surgery, is it endoscopy, or is it arteriography and embolization? Well, we actually asked that question and studied that using our population of patients at Johns Hopkins. This is Jun An, who is a colleague of mine, actually from Korea, who has spent a year to work with us, and this is his study that he'll be presenting at the Pancreas Club. He looked at 4,500 patients who underwent a pancreatic duodenectomy at our institution, and he identified 87 cases of a delayed bleed. The median age was 64 years old, and the time from bleeding, from the operation to bleeding, was on a median of 12 days. So as you can see, most of these are delayed. The overall mortality in our group was 15%. Now I asked the question, what if we do, and at one point in our institution, these were managed by either endoscopy or arteriography and sometimes surgery, and so it was a mixed bag. So he took all of these patients and he asked the question, what if we do EGD first, or endoscopy? And if you look on endoscopy, in 20 patients out of 37, they were negative. And of those negative patients, they ended up going to arteriography, and the majority of these patients turned out to have a pseudoaneurysm that was embolized by arteriogram. 13 of these required a re-embolization, or were embolized, and several required a re-embolization. Now, if you take the ones who were positive, they had no intervention by EGD. They just had a scope and were found to have an ulcer, and they were treated conservatively. One of these was required to go to embolization. 7 in the negative group and 4 in the positive group ended up going to surgery in a delayed fashion to control infection. So in total, of these patients who initially underwent endoscopic management, 16 of them required angiography and 11 of them went to surgery. There were 6 deaths in the group. Now if we look at the other approach, in which we had 41 patients in which angiography was the first mode, and of these, the majority of them were positive. So 23 of the 41 were positive, and they were managed through arteriography, and the success rate was relatively high, 19 of 21 on the first round. Even in the ones who were negative on the first round of arteriography, 10 of these patients underwent a repeat arteriography and were positive, and the bleeding was controlled by embolization. And 12 of these patients had to undergo exploration. There were 7 deaths in the group. So in summary, 33 of the 41 had a positive angio. None required an EGD, and there were 12 explorations in the long term. So we next asked the question of what are the associated complications. And if you look, pancreatic fistula and intra-abdominal abscess, which is really another manifestation of pancreatic fistula, far and away was the single most important risk factor. Second was bile leakage. And the two together were essentially synergistic. Now the other thing that we discovered is patients who have these catastrophic bleeds typically have what's called a herald event, and this is where it's important and where I think is an important teaching point. These sentinel bleeds, such as a small amount of hematemesis, hematochezia, blood in a drain, or an abrupt drop in hemoglobin in somebody who looks well but has a pancreatic fistula or a pancreatic leak, is a concerning finding. Another herald sign is somebody who's doing fine and then suddenly has tearing back pain or abdominal pain, which is usually a ruptured pseudoaneurysm. And finally, of course, hemodynamic compromise, which includes hypotension and tachycardia. So taking all of these together, all of these data, what have we learned? Well, the most common cause of a delayed bleed is a pseudoaneurysm. So EGD is not helpful usually as a first modality. The pseudoaneurysm carries a high mortality and can be associated with rapid exsanguination, so these patients should quickly go to arteriography. Arteriography is often successful in controlling the bleed, but it must be noted that even when it's negative the first time, that they often need to be repeated. A delayed bleed is strongly associated with a postoperative pancreatic fistula or biliary leak, and one must note that even after initial control of a delayed bleed, the need to go to the operating room to deal with infectious complications is high. Now, a surgery first approach, however, is associated with a high mortality, as you saw from the decision tree. Now here's an example of a pancreatic fistula. This is a patient of mine who underwent both a Whipple and a distal pancreatectomy for 2 lesions in the same patient. He leaked from both anastomoses. Another patient who has bile leakage is shown here. In these types of patients with either a pancreatic fistula or a bile leak, these are the ones that we need a heightened sense of awareness. So in a patient like this, if they have one of those Herald events, what should we do? Well, in a patient with these risk factors in a Herald event, they should go directly to angiography. If it's negative, they should go to for a CT scan to try to identify a pseudoaneurysm. The arterial sheath should stay in place, and the arteriogram should be repeated within 12 hours. They should remain in the ICU. If this remains negative for the first 24 hours and the CT is negative, then in a controlled setting, an EGD is acceptable, for it may be a marginal ulcer or a luminal bleed from a staple line. And postoperative pancreatic fistula or collections should be aggressively treated. They should not be allowed to bathe the specimen. So PTC, biliary drain, should be placed for pancreatic fistula, and percutaneous drains for uncontrolled pancreatic leaks. Here's an example of a case. You see the arrow is pointing to a pseudoaneurysm, a patient with a delayed bleed, and you can see that coils were placed in the GDA, and this actually controls the bleed nicely. The patient did not need to go to the operating room. Here is that case of the pancreatic leak that I showed you. Again, our interventional radiologist helped us put a percutaneous transhepatic biliary drain through the anastomosis, and that treats the problem. So aggressive treatment of these situations. Now let's move to the second complication, and this is a chyle leak. So a chyle leak is another uncommon complication. Its prevalence is about 1.3 to 6%, depending on the study that you look at in the literature. However, it is potentially lethal. Now, the lethality is not the same as with the delayed bleed. It's more of a slow, gradual mortality, and this is from chronic fluid and electrolyte imbalances, malnutrition, in particularly the fat malnutrition, as well as fat-soluble vitamins, and immune impairment. They are identified as a milky drain output once a diet is reinstituted. The drain output is triglyceride rich. It's typically defined as 110 milligrams per deciliter. We classify them as either high volume or low volume, and we usually make the cutoff at approximately 200 cc's a day. We also, an important distinction, as you'll see, is a contained leak versus chylous ascites. Now, what is the best way to manage a chyle leak? Once again, we asked this question, and we did a study at our institution where we looked at 3,500 patients. This study is now somewhat dated. We published it several years ago, and it was a retrospective analysis where we assessed the rate and risk factors and outcome of patients with a chyle leak. We had 47 patients of these 3,500, or 1.3%, who developed a chyle leak. 34 were contained, and 13 were associated with chylous ascites. We did a matched paired analysis in a 1:3 ratio. Now, in this cohort, the median day of diagnosis of the delayed bleed was post-op day 5. The patterns of occurrence were localized collection, which was the most common, and chylous ascites, which was less common. Risk factors on multivariate analysis included the number of lymph nodes harvested or vascular resections, and this makes sense. What these are basically markers for are extensive retroperitoneal dissections, and in these patients, in particular patients who had neoadjuvant with vein resection, the risk of a chyle leak is higher, and so it's something to look for. Now, most patients, or 57%, required TPN, and most patients were malnourished, with 43 of the 47 patients having an albumin of less than 3.5. Most patients, however, resolved at a median of 15 days with conservative management, and that is just either a low-fat diet or NPO with TPN and drain management. However, 11 patients underwent lymphocytography with a sclerosing agent, and this was only successful in 1, so very seldom does it helpful. 3 underwent an exploration with an attempt at oversewing the cisterna chyli, and this was unsuccessful in all patients. And 2 underwent peritoneal cable shunts, such as the Denver shunt, and these 2 had good outcomes, and these had refractory chylous ascites. So an important distinction to make is chylous ascites versus contained chyle leak. A chylous ascites is associated with worse nutrition, fluid and electrolyte disturbances, has a higher rate of sepsis, and is more difficult to treat. In fact, 6 of the 7 refractory cases were chylous ascites as opposed to a contained chyle leak. The median time to resolution of chylous ascites was 58 days versus 5 days for a contained chyle leak. And of course, the mortality was much higher. As you can see here, those with a contained chyle leak did relatively well and died mainly from cancer-specific mortality, while those with chylous ascites actually died from malnutrition and electrolyte disturbances. So the recommendations for the management of chyle leaks are NPO and TPN for the high-volume leaks, a trial of low-fat or short-chain fatty acid diets for the low-volume leaks, and if they become a high-volume leak, is then put them back on, make them NPO and back on TPN. Aggressive use of antibiotics to control sepsis, and percutaneous drains for undrained collections. The key in getting patients through this is drain management. So the drains must be kept in long enough to establish a tract. You should shoot a sinogram through the drain to look at the size of the cavity, and when the cavity is small, the drain should be slowly removed. I think a big mistake, and I've made this mistake, is do not convert a contained chyle leak into chylous ascites by early removal of the drain until the tract is formed, because then you create a small problem, a bigger problem from a small problem. And finally, you should attempt lymphoscintigraphy in refractory patients. Surgical closure is seldom successful. We no longer attempt this, except when we may be placing a shunt. So here's an example case of a 56-year-old female who underwent a total pancreatectomy. She had 63 lymph nodes harvested, so a high lymph node harvest. She recovered well, but presented back to clinic in post-op week 3, and you can see a large chylous collection here. We percutaneously drained this and managed her as we described, and she went on to recover completely. So in summary, mortality from pancreatic duodenectomy is low, but morbidity remains high. The most common complications are post-op pancreatic fistula, delayed gastric emptying, and wound infection. However, chyle leak and delayed bleed, although rare, are complications that can actually have a high mortality, and we can intervene to reduce the risk of mortality. And the proper management of these is important to reducing that risk. So I'd like to thank you for your attention.